We'll talk about the fluid management in the ICU, answered with the most frequently asked questions. Fluid management in critically ill patient passing through different phases. We start by resuscitation phase when the patient admitted to the ER, then followed by admission to the ICU. We start the second phase, which is the optimization phase, then followed by the stabilization in the ICU till patient discharge at day 5 or 7. In each phase, there are different amount of the fluid given to the patient. During resuscitation phase, the patient receive a much amount of volume. Then the amount of the volume decrease and the patient passing from the optimization phase, stabilization phase till patient discharge. And this can be achieved or demonstrated by what's called Rose concept. The Rose concept demonstrates the relationship between the volume of the fluid therapy on the y-axis versus the time from the admission till discharge on the x-axis. And these give this pattern. The amount of the volume is very high during the resuscitation phase because the resuscitation phase, the objective in this phase is to have a shock reversal, which is usually take a minutes or hour or the few hours, then followed by optimization phase to maintain the tissue perfusion, then followed by stabilization phase, which is the objective is to avoid fluid accumulation, and followed by a evacuation phase to remove the excess fluid from the patient, which may take weeks to achieve this goal. So in all these phases, we have a different questions. From resuscitation, optimization, and stabilization, we have to ask what is the ideal fluid to be used and how much volume do we need. On the other hand, in the evacuation phase, we need to ask when you decide to remove the fluid and how should we remove this fluid. First of all, what are the types of the fluid therapy we are usually used in the intensive care? We have crystalloid and colloid. In the crystalloid, we have either hypertonic solution like saline 3% or isotonic like saline 0.9% or ringer lactate or ringer acetate. And the difference between these two types of the fluids, the saline is called unbalanced solution and lactated ringer is called balanced solution. And lastly, we have an hypotonic fluid like dextrose 5%, 0.25% sodium chloride. On the other hand, we have a colloid solution, and the main colloid used in the intensive care is an albumin. The choice of the fluid depends on the three important factors: the phase of the resuscitation, whether in the resuscitation or optimization or the stabilization phase, the type of the patients, we are dealing with a critically ill patient or traumatic hemorrhagic patient or traumatic non-hemorrhagic patient. And lastly, what is the associated comorbidities, whether it's acute respiratory failure or acute kidney injury or liver cirrhosis. We start by the first question in the first two phases. What is the ideal fluid to be used in the resuscitation and the optimization? And the objective mainly is to recruit the intravascular volume. So first of all, should we use a colloid or crystalloid? If you look to the guideline, which is a European guideline on intensive care about the current practice on the fluid therapy, these are part one with the choice of the resuscitation fluid. The type of the patient, whether it is critically ill patient or traumatic hemorrhagic patient. For critically ill patient, if a patient have a sepsis or acute respiratory failure or acute kidney injury, we use crystalloid rather than the albumin. While if you have a cirrhosis, you use albumin rather than crystalloid. In traumatic hemorrhagic patient, in traumatic brain injury, use crystalloid rather than the albumin. In trauma, you use also crystalloid rather than the albumin. The second question is whether you have to use a balanced or a non-balanced solution. If we look to this meta-analysis that compare the balanced crystalloid versus saline systematic review, as we see here, if you are using balanced, we have a very slight reduction in mortality by about 0.4%. That is why in most of the patient used balanced rather than the saline if you have a patient with sepsis. For acute kidney injury, we have five studies tried to answer the question whether with the balanced or normal saline is safe for the kidney. Three of them found there is no difference between the saline and balanced solution, and two of them favor balanced solution. That is why In critically ill patient and have an acute kidney injury, the resuscitation fluid is using balanced rather than saline. For trauma, in traumatic brain injury, if you look to this study that it's a second analysis of the old clinical trial of the study that you compare the balanced versus saline versus balanced crystalloid versus saline, we found that the number of the patient discharged to the home is significantly higher in saline versus balanced. That means that the patient receiving saline have more likely to discharge the home rather than the balanced that they are discharged to the rehab centers. And lastly, for trauma patient, whether to use saline or isotonic saline or hypertonic saline. And the idea for using the hypertonic saline is to use a small volume resuscitation. As we see here, there's all these studies that compare the saline 0.9% versus saline 3%. There is no difference in the outcome between both of these solutions. That's why the recommendation is to use isotonic rather than hypertonic in trauma patients. The second question is how much fluid do we need? The second part of the consensus try to answer this part, which is the volume of resuscitation fluid. The volume therapy in shock can be divided into patient with septic shock and patient with hemorrhagic shock. For septic shock patients, we started by lactated ringer solution 30 milliliter per kilogram over 3 hours. This is the resuscitation phase to achieve mean pressure more than equal or more than 65 millimeter mercury. Then we move to the second phase, which is optimization phase, which look at the optimization of the tissue perfusion by checking the capillary fill time. If the capillary fill time less than 3 seconds, we continue to monitor the patient. If the capillary fill time more than 3 seconds, we check the fluid responsiveness. If it is positive, we restart lactated ringer, small volume between 250 to 500 over 30 minutes, and recheck again capillary fill time. If it is negative, we will seek for alternative therapy. This is how we will go for resuscitation optimization in patient with septic shock. And if we have a patient with cirrhosis and hypotension, we started by lactated ringer 500 milliliter or albumin 5%, 250 of milliliter. Then after 30 minutes, we check the mean pressure. If we are achieving this goal, we continue as a maintenance fluid of lactated ringer of 1 to 1.5 liter per day plus albumin 20%, 40 to 60 gram. If we do not achieve the mean pressure 65 millimeter of mercury, we give a second bolus of lactated ringer 500 to 1000 or albumin 5% 250 or 500 milliliter. Then checking again the mean pressure. If we are achieving the goal, we will continue maintenance therapy. If we did not, we will start vasopressin. This is how we give the amount of the volume in patient with cirrhosis. What about the trauma patient? We can split the patient into trauma patient without traumatic brain injury and trauma patient with traumatic brain injury. In patient without traumatic brain injury, we started by lactated ringer, small bolus of 100 to 200 milliliter boluses to achieve systolic blood pressure 80 to 90 milliliter of mercury. Then we continue resuscitation after control of the bleeding. But in trauma patient with traumatic brain injury, we'll give the same amount of the fluid, but with saline, not with lactated ringer. And to target systolic blood pressure a bit higher than 80, 90 is 110 millimeter of mercury. Then after controlled bleeding, we'll continue the resuscitation. The second phase is stabilization phase, and the idea is to avoid fluid accumulation. So what is the ideal fluid to be used? And normally the daily losses from the any patient is mainly caused by the urine output and the sweat, and both these output have a low sodium content, about 20 to 30 milli equivalent per liter. So the maintenance fluid should be have a low sodium content. Either we are using dextrose 5% 0.25 sodium chloride, or we have a mix between 2 bags of dextrose 5% plus 1 bag of saline if you don't have this solution in your setting. So what about if we are using saline as a main crystalloid as a maintenance therapy in our ICU each day? If you look to this fluid balance and sodium balance, if you are giving For the 3 days, we give saline 2000 milliliter, and you have a urine out 2000 milliliter. We have a perfect zero fluid balance. But the problem here, the 2000 milliliter, we have in about 300 millimole of sodium, and as we said before, the urine output have a low sodium content, so the 2 liter of urine output contain 80 millimole of sodium, so you have a more in sodium than out sodium, so we have a positive sodium balance. The problem in the positive sodium balance that the sodium accumulate in the interstitial space, and this make accumulation of the fluid in the interstitial space and cause edema formation. So the high sodium balance cause fluid accumulation even we have zero fluid balance. The second problem in the maintenance phase or the, dextrose 5, of course, for brain injury patient, we may avoid dextrose 5% as a maintenance fluid and use saline. This is the only exception. If we have a brain injured patient, we don't use dextrose 5% as a maintenance fluid and use saline instead, because to avoid aggravation of the brain edema. The second problem that the if you are dealing with if you are dealing with a patient in the ICU, we usually notice that we prescribing a fluid, a daily fluid, but when we are looking at the actual fluid the patient received, we have much amount of volume the patient received than the prescribed fluid. This is called what's called fluid creep. The fluid creep is the amount of the fluid received by the patient is much higher than the fluid prescribed by the physician. And the main cause of the fluid creep is that the volume of the dissolving or diluting solvent for intravenous or intra drugs or electrolytes, which are not intentionally used but may have a significant impact on the fluid volume. The main problem is not about the volume of the fluid creep, but the nature of the fluid creep, which is mainly caused by the saline, because the saline mainly used for dilution of the drugs and electrolytes. And this is the study that tried to show the impact of the fluid creep on the volume and chloride load in a critical ill patient. As we see here in the day one, this is the amount of the maintenance fluid, and this is the amount of the resuscitation fluid, and this is the amount of the creep fluid. 50% of the volume received by the patient are not intentionally prescribed by the physician. And this is exactly what happened in the second day. The maintenance and resuscitation fluids decreased, and in the third day and also in the fourth day. As we see here that the creep constitute 50% of the amount of the fluid given to the patient. And the impact of this, as you see here, the number of the patient receiving renal replacement therapy is significantly higher in patient having high fluid creep than the patient have a low fluid creep. The death is higher, and also that hospital stay is higher in patient with high fluid creep. So the high fluid creep have a bad impact on the patient. How can we avoid fluid accumulation in this phase? First of all, we need to ask if this patient eating or not. If the patient is eating, we need to calculate the oral fluid or oral feeding plus fluid from other sources. If this exceed or equal to 200 to 25 milliliter per kilogram, we need to stop the maintenance fluid. If not, we start maintenance fluid. So we start maintenance fluid by giving dextrose 5%, 0.25% sodium chloride. And how to calculate the maintenance fluid? We need to subtract the all fluid from other sources from the 25 milliliter per kilogram. So if we have a diluent fluid or drugs, for example, 1000, 1500, we will calculate 250 to 25 milliliter per kilogram minus 1000 or 1500 milliliter, and this will be the amount for the maintenance fluid given to the patient. Lastly, we go to why want to remove the excess fluid from the patient, the evacuation phase. The problem here, if you look to the Rose curve, if we continue resuscitating the patient by giving many more aggressive fluid, the patient will eventually die. And even if in the optimization and stabilization phase, if the curve like that, for example, we have a lot of fluid accumulating in the patient, we have a prolonged ICU stay, and if the patient is mechanically ventilated, the patient eventually will be tracheostomized, and there is a lot of disability on this patient. So Actually, we need to decrease the time from going from the stabilization to the evacuation to minimize all these complications that can happen in the ICU. So, when and how should we remove fluid from the patient? We have three important things to ask to answer this question, the active resuscitation step. First of all, we need to identify patients suitable for resuscitation. Three important things. Objective measure of the volume overload. There is no sign of hypoperfusion, minimal dose of vasopressor. If these three factors is okay, so this patient is ready for the resuscitation. The second thing, the set fluid removal protocol. Establish a 24-hour fluid goal and identify how should we remove this fluid. The third one is to monitor the response. For example, this patient improved or not. Second thing, which is very important, is to set a safety limit criteria. For example, if the blood pressure dropped or increased the capillary fill time, we have to stop removing fluid from the patient. We start by first thing is how to objectively measure the fluid overload. To answer this question, we need to identify that the effect of the fluid overload is different among the patients. If we're giving fluid to the patient, you can see that one of the patients who have increased both intravascular and interstitial expansion of the intravascular or central volume and interstitial space. But on the other hand, some patients we have only expansion or accumulate on the interstitial space with little effect on the intravascular volume. So you might find these patients like that. You have patient with a high CVP with no or minimal edema. On the other hand, you have a patient with a low CVP and marked tissue edema. Both of these patients are called at the volume overload. So in a way or another, we need to have a multiple parameters approach for diagnosis of the volume overload. So diagnosis of the volume overload, we need to look to add one of the three important parameters. First of all, look to the cardiac filling pressure by looking to the lung, for example, lung ultrasound. You have to look onto the intravascular congestion by looking to the IVC. And importantly, you need to look to at the tissue congestion, for example, pleural effusion or ascites. Any of these patients mean any of these, if any of these signs are present, this patient mean that patient have a volume overload. The second thing, we need to establish a protocol. One of the methods that of the how to resuscitate the patient as mentioned in the critical care in 2020 uh, by this review by this type of methodology. First of all, we need to determine the patient-specific daily fluid balance goal. For example, I need to have -1 or 2 liters per day. Second thing, that if that patient if have not known to be have a furosemide exposure, we will start by a dose of furosemide based on GFR. If the GFR more than 50, we give 40 milligram of Lasix. If the GFR from 30 to 50, we give 60 milligram of diuretics. If the GFR less than 30, we give 80 milligram of diuretics. But if the patient have a previous exposure to furosemide, we will start by the initial previous dose that the patient responding to the furosemide. For example, if the patient responded to the 80 milligram, we will start by 80. If the patient respond to the 40 milligram, we will start by 40. If there is no response to this, we will double the previous dose. The more important thing that we need to reassess after 2 hours. If the goals after 2 hours are achieved, we will set this dose every every 8 hours, which call, and after 8 hours we make an 8 hour assessment. But if after 2 hours the goal is not achieved, we need to double the previous dose up to 200 milligram and call 2 hours assessment. This is a very important part in the protocol, that the assessment should be after 2 hours. Did we achieve the goal of the 2 hours that will have the final goal of -1 to -2 liters or not? If the goal is achieved, it's okay. We will give every 8 hours. If not goal is achieved after 2 hours, we will double the previous dose up to 200 milligram. And interestingly, in patient with interstitial edema, if we wrap the upper and lower limb, when this study show that the manual decongestion therapy by wrapping the upper and lower limb with crepe bandage, and this manual decongestion improve the hemodynamics. And to finalize the fluid therapy in critical ill patient, the goal in resuscitation phase is to shock reversal. The optimization phase is to maintain perfusion. In stabilization phase, avoid fluid accumulation. In evacuation phase, remove excess fluid. The type of the fluid in resuscitation and optimization phase is balanced crystalloid in septic shock, except in traumatic brain injury, we give saline. In stabilization phase, we give like 5% 0.25 sodium chloride. In evacuation phase, we store fluid. The volume in resuscitation phase is 20 to 30 milliliter per kilogram in septic shock, and in optimization 250 to 1500 milliliter in 30 minutes. While the in traumatic and hemorrhagic shock, we give us very small boluses, 100 to 200 milliliter bolus to achieve blood pressure of 90 milliliter of mercury in non-traumatic brain injury and 110 millimeter mercury in traumatic brain injury. While in stabilization phase is the goal is to give fluid volume about 25 milliliter per kilogram per day, and in the evacuation phase to become negative in -1 to -2 or 3 liters per day. The monitor for resuscitation phase mainly in about the pressure, optimization phase, the tissue perfusion, capillary fill time on lactate, stabilization, avoid fluid creep, and evacuation. Again, we have to remonitor the pressure and capillary fill time to avoid excessive evacuation. Thank you.